Okay. Can you see my screen?
Yes, it is visible.
Okay, thank you so much. So good evening, everyone. Welcome to this webinar of INDIGO, which is Introspections and Deliberations in Gynae Oncology. The topic we have chosen for this month is HRD testing and how, as beginners or someone who have maybe a little knowledge about what it is, because we are not dealing with it directly, as at least as surgeons. And I hope there are some other medical oncologists and radiation oncologists also in the group who have understanding but want to increase their in-depth knowledge of, what a test means and what all should you see and why this is important. So good evening. I'm Dr. Neha Kumar. I'm a senior consultant in Gynae Oncology at Amrita Hospital, Faridabad. And this webinar is in association with Delhi Gynae Oncology Forum. So why have we taken up this topic? We have taken this topic up especially in relation to ovarian cancer, although like Dr. Moshmi said, the HRD testing is now coming up in a big way, even in breast cancers and now in prostate cancers. But this being a gynae oncology group, the reason why we took this topic up is we all know that high-grade serous ovarian cancer is genetically unstable and it has a high mitotic rate. It has pathological variants in TP53 and alterations in BRCA1 and BRCA2. About 15% of these tumors present with germline mutations in BRCA1 and 2, and 6% may harbor some somatic variants. But what is very important is that up to half, that is almost half of high-grade serous cancers, they show defect in homologous recombination repair pathway. This will be discussed in detail with Dr. Moshmi, but the reason why this is important is because there have been several trials which have shown the benefit of PARP inhibitors in the patients who have a defect in homologous recombination repair pathway. And if we were to include just the germline mutations, we would be missing a big chunk of patients who have this defect present somatically, and other, all these trials have shown that even in these patients, addition of PARP inhibitors has actually shown to improve the survival. So in high-grade serous cancers, homologous recombination deficiency, it is either caused by pathogenic germline or somatic variants and epigenetic modifications in BRCA1 or BRCA2 genes, or other genes which are responsible in the HRR pathway. And these are basically all these genes like RAD51, ATM, CHEK2, and all these genes. So all these genes basically, besides BRCA1 and BRCA2, these are other genes which confer an HRD or BRCAness phenotype to the tumor. And this can potentially enable patients who have these mutations to receive PARP inhibitors, which have shown an improvement in survival. Even in India, this was a big study, where they studied the mutations in breast and ovarian cancer using a multi-gene panel. And they found positive mutations in up to 30% of patients of high-grade ovarian and breast cancers. Most of these mutations, about 85% for BRCA1 and BRCA2, BRCA1 being 65% and BRCA2 close to 20%. But 15% of these mutations were in other minor genes, which would be missed in if you did only a BRCA1 or a BRCA2 test. And why this is important is because now in the algorithm of advanced ovarian cancer, once we treat the patient, that is, the patient has undergone surgery, whether it is primary or interval, and we have to follow it up with adjuvant chemotherapy. We should know what is the BRCA status. If BRCA is positive or there is a homologous recombination deficiency, we can put these patients on maintenance olaparib with or without bevacizumab. However, in case it does not show any mutation, these patients are less likely to be benefited by PARP inhibitors and are, either kept only on observation or maintenance bevacizumab, depending upon the situation. So I'll now be introducing Dr. Moshmi Suryavanshi. She's a distinguished clinical scientist with over 24 years of extensive experience in molecular diagnostics and translational research. She's MD Pathology with training in Oncopathology, PhD, FRC Path, UK, and Masters in Molecular Oncology. She has several publications to her credit, and currently she heads the Department of Molecular Biology at Amrita Institute of Medical Sciences and Research Center, Faridabad. Over to you, ma'am.
Yeah. Can I share? Have you allowed me to share my screen?
Yes, you should be able to share your screen. Yeah. You can share your screen, ma'am. Just open your PPT. Yeah,
Just.
yeah. Open your PPT. Yeah, that's fine.
Okay. Okay. Can you see my slide?
Yes, we can.
Okay. Good evening, everybody. And thank you, Delhi Oncology and Dr. Neha, for giving me this opportunity. So, I have been given the task to have this webinar, Understanding HRD, a Beginner's Guide. I will try to make it as simple and as understandable as possible. But still, if there are any queries, I'll be happy to answer them after the webinar. Okay, so before we start with HRD score, so I want you to understand the basic concept. So you, me, all sitting here are having a lot of mutations going on inside our body. They may be due to the air we breathe, or due to the light we are under, or maybe something some pollution or something. But there are many major repair pathways in the body, and amongst them, there are five repair pathways, which I think we all should know of. So they are base excision repair, nucleotide excision repair, mismatch repair pathway, which I think most of us know as homologous recombinant repair, and non-homologous end rejoining. So these are the major repair pathways. So whenever there is any mutation which is happening, there are thousands and thousands of mutations happening every moment. So these repair pathways come into action and they repair the mutation which has occurred. And if the body is unable to repair, it programs the cell to die. The cell finally die. So what we know so far is that under certain conditions, like because of UV rays, there are usually these nucleotide repairs which cause bulky lesions or crosslinks or these kind of things. And when there are these mismatch repair, which I think most of us know that these are the MSI testing which we do by IHC or by PCR, and we see mutation in the MLH1 gene, MSH2, MSH6, and PMS2 genes, which are usually tested for these. And when there are these mismatch repairs, so these kind of repairs in the single strands or replication repair errors occur, and which lead to cancer. And then there is this homologous recombinant repair, which is very important with the context of today's lecture. So these are very high fidelity repair, and they are usually bulky, double stranded repairs. So both the strands of the DNA usually get defective and they are repaired, and they are repaired by homologous or non-homologous recombinant repair. In homologous, which is called the high fidelity repair, usually there are multiple genes involved, and the common ones which we usually know of are the BRCA1, BRCA2, ATM, RAD50, CHEK2, and so on. So why we are not usually talking about the other repair pathways and mostly talking about the mismatch repair or MSI or homologous repair? Because today we have certain drugs which are available against these repair pathway. For MMR or MSI, we have immunotherapy, and for homologous repair, we have Parp inhibitors. So that is why most of the concentration is on these two repair pathway. But besides these, there are other repair pathways like MGMT, which are also there. But presently, we don't have any drugs for them. But maybe tomorrow, if we have drugs for them, we will be discussing them in detail. So then the other concept I want you to understand before we go to the HRDs, what is the origin of this HRD score? So where has it come from? It has come from mutational signature. So all the cancers have some archaeological record in the form of certain mutations in them. So these mutations, these archaeological records are like signatures. And these signatures are very significant towards the etiology. Say, for example, if somebody has smoking as the cause of cancer, maybe lung cancer, so there will be a particular signature related to tobacco. There could be a particular signature related to UV light. And similarly, there are particular signatures which are related to these homologous recombinant repair pathway genes. So these kind of signatures are significant. So it is not necessary that you have mutation in these genes, the HRR genes or the homologous repair pathway genes, but if the signature is there, it is likely that the drug, that is the Parp inhibitor, would work. So that is the main philosophy behind these HRD scores. And from where did these signatures come? So this is from TCGA. So what we have done is, in fact, this is mainly done in US. This is a repository of tumors where they have sequenced thousands and thousands of tumors, and they have done the whole genome sequencing, and then they have found these signatures. So say, for example, there are these changes like from cytosine to thymidine. So from cytosine to adenine, from cytosine to guanine, and so on. These are the changes in skin cancer, which is caused by ultraviolet rays. If you can see, most of the mutations are C to T. There is conversion from C to T. And if you just look at lung cancers caused by tobacco, there is predominance of C to T and C2A. Even in the same C2T mutational signature may be different. So say, for example, in skin cancer, most of the C2T conversions are in the area where the sequence or the codon is TCG. And in the lung cancer, the same C2T conversion is in the area where it is the codon is ACG. So that means there are around, I'm not getting into the details of this. This is just to make you understand the concept. There are around 96 permutation combination which are possible. And based on those permutation combination, what type of these substitutions are more common, these signatures are established, and they are not so simple. They use bioinformatic algorithms based on which these are established. So initially there were around 30 signatures which were there, and signature 3 is the one which is your homologous recombinant signature. Besides this, there are other MSI-based signatures, and as I told you, aflatoxin-based signatures, tobacco-based signature, aging signatures. So these are available. For if you want to see, these are available in Cosmic. You can go and have a look at them. So with that basis, so ideally the signature or HRD score should have been seen in whole genome or whole exome sequencing. But to do a whole exome sequencing will not be possible for all tissues. One, we are using FFP, and to replicate the same thing which was done on a fresh sample may not be possible. And of course, the cost and everything would increase. And as a surrogate to this, there are these panels, which are smaller panel, which give something like a HRD score, which is reflecting these type 3 or a homologous recombination deficiency signature. So there are various ways which we can find if there is a homologous recombinant deficiency signature, which can be used as a biomarker. One, I told you the mutational signatures, which clinically is not used. So this is when you do a whole genome or whole exome sequencing, and that also on a fresh tissue, you should be able to see these kind of thing based on the bioinformatic algorithm. Then there is when you test for germline BRCA1 or BRCA2 mutation, as it is done in most of the ovarian cancers. It is a universal testing thing. You do a germline or somatic testing for these genes. So if these mutations are present in these genes, it is likely that these patients have that signature of homologous recombinant deficiency. So it's like a surrogate for that. And similarly for the somatic other HRR gene mutations. Then there are these genomic scars, which we also called as a sum, the HRD score, which I'll be talking about. So this is a sum total of certain factors, which I'll be talking about. And then there are these functional homologous recombinant assays, which I think we are not talking about, but I think in future we will be talking a lot about them. And then there are these gene expression signatures of BRCA. These are basically the expression of genes which are expressed at the RNA level. So what I showed you previously was at the DNA level, but if you have the expression at the RNA level, so these are the expressions of BRCA. We are again not testing clinically for them because it will be a huge exercise for a tissue sample. And you have to also think of something which is cost effective. So most cost effective would be a germline or somatic testing, and maybe to some extent HRD scoring, and maybe in future functional HR assays. So what is the definition of HRR genes? So everybody keeps on saying these are homologous recombinant genes. So what are these? So ideally, to be very honest, there is no universally defined definition of a HRR gene list, which can, if mutated, cause these these homologous deficiency. But different trials have used different genes. So, but what is common in all of them is BRCA1, BRCA2, ATM, BRIP1, and CHEK2, and PALB2. So these are common to all, but besides these, there are other genes which are known to be associated with HRR genes. So everybody can have their own definitions, but at least these genes should be included. So let's look at ovarian cancer. So if you look at ovarian cancer, as Dr. Neha had mentioned in one of her slides, that almost 51% of the ovarian cancer is homologous recombinant deficient. So if you just split it, how does it look like? So there are around 8% germline BRCA1 mutation, 3% somatic BRCA1 mutation, around 6% BRCA2 mutation, 3% somatic BRCA2 mutation. Similarly, around 10% is BRCA promoter methylation, which is an epigenetic change. So nobody is testing for this. And then there are CDK12 mutation and other HRR gene mutations. And then there are certain mutations like loss of PTEN, loss of both arms, homologous loss of PTEN, or EMSY gene amplification. These also are known to show that these tumors also have homologous recombinant deficiency. So, and there are some tumors like which have cyclin E1 amplification. They are homologous proficient. In fact, it's a mutually exclusive. If you do a sequencing or a comprehensive genomic profiling of ovarian cancer and you find a cyclin E1 amplification, it is unlikely to be HRD score positive or HRR deficient. So these are mutually exclusive. But what I want to show you here and highlight is that most of the mutations, BRCA or non-BRCA, can, like 51% of them, can lead to that signature 3 or homologous recombinant deficiency signature. So our aim is to find out that signature, and we are using various types of testing. So if you just test for BRCA1, BRCA2, or just the HRR genes, we would be missing at a chunk of patients which could have benefited from Parp inhibitor therapy. So then coming to the main topic, the HRD score. So what we are looking for in HRD score, of course, the HRR mutations, they are direct evidence, but then there are certain indirect evidence like the promoter methylation. Like say, for example, the patient who has inherited a BRCA1 mutation in one of the allele from one of the parents, so the other allele may be silenced because of methylation. So what is methylation? Basically, these are increased methyl groups at the promoter part of the gene. So what happens? The gene cannot be switched off. That is, the gene is silenced. So say, for example, if one of the allele of BRCA1 is inherited from the parents as defective or as mutated, the other allele, which was normal, gets silenced because of methylation. And plus, there are other factors which I have mentioned about other genes and some undetermined causes. So all of them can together present a signature of genomic instability, that is the HRD signature. So currently there is actually for HRD score, there is only one FDA approved platform, and that is the Midriad Genetics My Choice HRD DX. Besides that, there is Foundation Medicine platform, which is approved for loss of heterozygosity score. So there are two scoring systems which are ideally approved. FDA, originally approved by FDA. Besides that, there are many tests which are available in the market which have validated against these tests and are equally useful. Okay, so let's come to the definition of HRD score. So we heard what is HRD score. When we are using HRD score, we are trying to pick up all the cases which could be HRD deficients, HRR deficients, or homologous recombinant deficients, which may not be BRCA positive. So this is what we are trying to pick up, which may not be HRR gene positive, but still they are deficient. So this is, so it's a formula, it's a bioinformatic formula. And since this is a surgeons forum, I will not go into the details, but still I will just give you a glimpse of it. It's basically a sum of three things which I will tell you. So the first is loss of heterozygosity. So we know that each gene in the body has two alleles. So say for example BRCA1, so one allele is coming from the father, the other is coming from the mother. So what happens? So what is loss of heterozygosity? It is the number regions of representing one parental allele loss. So that means, so one allele is lost either because of methylation or because of loss of copy number. The other is present. And there is copy neutral loss or there is original loss. So what do we mean by copy neutral losses? I told you there are two alleles for each gene. BRCA1 has two alleles, one from father, one from mother. So LOH loss will be one of the allele is lost. Only say, for example, the one which we got from our mother is there. But what is copy neutral? The copy neutral loss is the one allele is lost, like what I told you, and the other allele which was remaining has become amplified. So apparently it appears that it is normal. It is, there are two alleles, but the allele you got from your father for BRCA1 is lost, but only the one from mother is there and which is amplified. So that is the copy neutral loss. The definition is this region has to be more than 15 MB, but shorter than the whole chromosome. So that is the definition. And then the other component of the HRD score is the telomere allelic imbalance. So it is the number of regions of copy number gains or losses or loss of heterozygosity that extend to one of the subtelomeres but do not cross the centromere and are greater than 10 MB in size. Yes, these are bioinformatic definitions, but this is how it is classified. If you want to just go into the details, since we are talking about it, so that's why I'm telling you. If somebody wants to know even more about them, I can tell you about the details. So the third part of the HRD score, which is the large scale state transitions. So these are the number of chromosome breakpoints between the adjacent regions which are greater than 10 MB and they are short of whole chromosome. So basically HRD score is sum of all these three components. That is the number of LOH, TAI and LST. So the three components which I told you, they have to be added to get a score, and this is a bioinformatically generated score. And obviously, since we are talking of lot of MBs of data, this panel, the NGS panel, which has to find or come to this score has to be big enough. So let's see, how did this score actually come about? From where did Myriad My Choice Genetics come to this score? So this is a genomics card. This is basically a numerical representation of the genomics card of instability. So they use thousands of SNPs to calculate the score. So SNPs are single nucleotide variations, which are normal variations in normal people. So if there is a loss of certain part of chromosomes, those SNPs or those normal variations are missing. So these are not directly, you are not seeing directly the whole chromosome to see which part is lost, but you are seeing the SNPs. And if you see that, okay, 10 SNPs in random in consecutively are lost, that means this part of the chromosome is lost. So that is how they calculate it. So and along with the HRD score, Myriad actually gives only two genes, BRCA1 and BRCA2 mutations in only two genes. So they have come to a cutoff of 42, which was initially 42 and it's later been lowered to 33. So how did they come to this cutoff? So what they did is they took some 859 ovarian cancers, and then they calculated separately all these scores, all these three scores separately, and tried to figure out that the patients who were BRCA positive and the BRCA negative, was there anything which could bring a cutoff? Was there any score, a statistical score, which could divide them? So individually, none of the factors could divide the BRCA positive and the BRCA negative tumors. But when they combined all of them, when they added all of them, they could clearly see that here the red ones are the BRCA negative, and the blue ones are the BRCA deficient. So they could clearly see that there was a demarcation point or a score adding these three, where most, not all, but most of your BRCA positives or the ones which had similar things could be separated out. Okay, so there were, of course, cases which were not BRCA positive, but which were also BRCA intact, but were falling in this category. And then this score came to be somewhere between 40 and 45. So that's why the initial score of 42 was chosen. And then this was clinically validated by offering all these patients Parp inhibitors, and it was clearly seen. I will show you the graphs also, that the patients who were BRCA1, BRCA2 positive and HRD score positive, that is more than 42, did best. And after them, the patients who were BRCA negative but the score positive, they performed the second, and the worst performing were clinically the patients who were BRCA negative as well as the HRD score negative. So that's how this whole concept of HRD score came into being. This is a statistical concept. Okay, so they accepted tumors which were more than 20%, and the unacceptable tumors, because this whole test was validated on certain types of tumors. So what they did not validate it on were brain metastasis, bone metastasis, and endometrial tissue. So that was not validated on these. So that's why these are the conditions based on this, for this, ideally for this test. So then coming to the Foundation 1 test. So Foundation 1 has got FDA approval based on the Ariel 3 study for, I think, rucaparib, based on the LOH score. This is only the loss of heterozygosity score. So initially, I told you in the HRD score, there were three components. So here it has, Foundation 1 has validated, it's clinically validated its test based on only the LOH score, and they have given a cutoff of 14, which was reassessed and analyzed to a cutoff of 16. So I told you that besides these two tests which are FDA approved, there are other lot of other tests which have validated themselves against these two so-called gold standard tests, and they are also giving a good prediction, good answers. So amongst them are these Sophia Genetics, even Thermo Fisher, Illumina TSO 500. So, and Kaizen and Amoy DX, all of them are giving the HRD scores, though it is not same as the one which was validated by FDA, but they are quite comparable. So as also already mentioned by Dr. Neha, so where do we use these HRD score? In first line, olaparib can be used along with the bevacizumab when HRD score is positive in first line. And in later line, HRD positive patients, niraparib can be used. And for LOH score, all comers, where LOH is more than 16, or in second line maintenance, rucaparib can be used. So these are the indications where these can be used. And if you're using different panels, so different can be used. And another thing, so if you're using a panel by maybe Amoy DX or Kaizen or Thermo Fisher, their scoring or cutoff will be different. It will not be same. They will give you a scoring which has been compared.
Ma'am, your voice is breaking up. Maybe I think it's your internet connection. Can you hear the internet connection? Can you hear? One of the attendees has their microphone on. Can all the attendees please unmute themselves, please? Sorry, mute themselves. Can all the attendees mute themselves? Madam, go ahead. Dr. Moshmi.
Yeah, can you hear me?
Yes, we can hear you now. Yeah.
Okay. Can you see my slides?
Not now. You'll have to share again.
Okay, I'll do that. I don't know why I lost my connection.
Yes, we can see it now.
Where was I? I think I was here.
Yes, yes.
Okay, so this is the study where you can see the HRD score was used. And as I told you, the patients who were HRD score positive and BRCA positive, they performed the best. And then the patients who were who had the best progression-free survival, if they were BRCA mutation positive or HRD positive, and the patients who were BRCA negative but had a HRD score positive, also had a progression-free survival of 52%. So that is why this score and this cutoff has been used. Okay, this is the Ariel 2 trial for LOH, where the foundation test was used. And again, you can see that the patients who were BRCA mutant, they did the best, and they had the best progression-free survival. And then just following it was patients who were BRCA wild and LOH high, and then patients who were LOH low. So that is why these cutoff have been used, and they have significance. So there are certain limitations to these tests, and they are not, everything is not hunky dory here. So you see, like your PDL1 testing for immunotherapy, these HRD signatures are dynamic. These are dynamic. The patient may have initially started with maybe signature 2 or some tobacco signature, but later on, after mutations, further mutations may develop a HRD signature, or may initially have HRD signature and then maybe something else is adding. So currently the main challenge is, which is the main limitations also, and which you should understand, that it is obviously best if you can use the latest tissue to assess the HRD signature. But currently, the approved HRD test fails to reliably identify the group of patients who will not respond to a PARP inhibitor. So that is the main limitation. And as I said, these are dynamic tests. So it is not that it will remain static. There will be lot of signatures or lot of insults which will be added to the tumor and which will create a new signature, and the combination of the patient can have more than one signature also. So what each of those will have, what kind of effect that will have, we don't know so far. So that is the main limitation of these signatures. Okay, then I told you about functional assay. So what are these? These are right now, none of us is using them clinically, but I think it is high time we should start at least them with a research, some research project, and then finally have them. So in fact, in other countries, many people are using these functional assays. These are something like immunofluorescent tests, and maybe not like a fish, but something confocal microscopy. So where you can look at these RAD 55, 51 high or patients, where you can see them as these signals, which are like here, they are appearing as red signal. So these patients who have lot of these signals, that is the RAD 51 is functional. So patient is HR proficient. And so if the patient is homologous recombinant proficient, the PARP inhibitors will not work. So on the contrary, if you don't have these so many red signals, and of course there is a cutoff of more than 5, which has been seen and published in most of the publications on this, these patients are RAD 51 low, which is like a surrogate of your homologous recombinant deficiency. And these patients are likely to respond to PARP inhibitor. Now the question is, if then how good are these in comparison to the HRD score? So what literature says is that they have very good sensitivity. So sensitivity, you can see here, if HRD score, if you're comparing with HRD score, which is 100, then they are almost 90% sensitive. And if you just look at the specificity compared to your HRD score, which is just 57%, they are 96% specific. And accuracy is even more than your HRD score, 68% versus 95%. And if you just, okay, these are theoretical and these are test based, but if you check them based on the PARP inhibitor response, and you can clearly see that the patients who were HRD RAD51 low nuclei, they have responded to PARP inhibitors. So this may be the test of the future, or maybe HRD of the future. But and this even probably might be cheaper, this I feel. But yes, HRD score for now is the test which has been recommended. So just to give you a glimpse of how things are complex and they are not so uniform, this is a case, this is a real case. Okay. So this is a 48-year-old female. She was having serous ovarian carcinoma, and the patient was germline BRCA2 mutation positive with her HRD score of 72, which is obviously a high score, since I told you a cutoff of, actually, this is a Kaizen panel which had a cutoff of 65. And even for 65, 72 is a high score. The patient was started on PARP inhibitor with bevacizumab, and the patient stopped responding after 6 months of treatment. So now the patient, a comprehensive genomic profiling both on liquid biopsy as well as tissue was sent. And these are the reports. So what you can see in the comprehensive genomic profiling, these are the highlights of the reports. So obviously there is this BRCA2 mutation, which was originally a germline mutation, as mentioned earlier. This was present. And then along with some other mutation, the TMB, the tumor mutation burden, was low, and the MSI was stable in NGS. So, and the liquid biopsy showed, of course, the same mutation with a variant allele frequency of 50%. Since this is a germline mutation, so 50%. So it, as I told you, that one of the allele is damaged. So the 50% of the BRCA2 is mutated. So that's why the variant allele frequency is so high in liquid biopsy. And along with this, there is another BRCA2 mutation, which is a large deletion in the exon 4 to 10. And plus, there are same mutations which were there earlier in the tissue. And the tumor mutation burden is also low, and the MSI is also stable. So, what we find in the liquid biopsy, there is another BRCA2 mutation which is happening, and the patient has stopped responding to PARP inhibitor. So, what has happened? So if you just go, so this is how we see the mutation. So if you just go and see, this is the genomic data viewer. This is NCBI. We usually use NCBI for PubMed. But besides that, there are a lot of other things which can be done on there. You can go and analyze your genes. So this particular mutation is a stop mutation. So what happens is a codon, stop codon is formed. So when a stop codon is formed, so what happens? The protein does not extend beyond that thing. Only, say, for example, I'll just show you. So if this is the area of mutation, so this is exon 10, this is exon 9, this is exon 8, this is exon 7, 6, 5, and 4. So here the mutation has occurred. Since it's a stop mutation, the further protein, that is from 11 onwards, if it is BRCA2, it has some 27 exons, so they will not be formed. So this is a defective thing. So BRCA is non-functional. So, but what has happened? There is another mutation which has happened, which is like a body's or the cancer's mechanism to revert back. Okay, where there is a deletion from exon 4 to exon 10. This mutation, this area is deleted. So if this is deleted, the exon 3 will fuse with exon 11 and reform a new BRCA, which is not like the original, but it is still functional. I'll show you. So if you just look at the BRCA2 gene, So this is the exon 11 area, which has BRC repeats, which is the main functional area where all the functions or the main work of the BRCA2 gene occurs. So earlier there was a germline mutation in exon 10 somewhere here, and that is why, and there was a stop mutation. So this part of the BRCA2 gene or the protein was not formed. So now there is another mutation which cuts off from 4 to exon 10. This part is cut off, and there is reunion of exon 3 to exon 11, and there is dysfunctional BRCA2 protein, but it is still functioning. And there is uh, uh, refunctioning of the or retention of the BRCA2 function. So these are called reversion mutations. These are very common in patients who have undergone cisplatin or PARP inhibitor therapy. And this is usually happens when clinically you can suspect these mutations when the patient stops, who was earlier responding to these treatments, stops responding to them. So we currently don't have any thing against, like, or we don't know anything what we can do for these patients. But there are in fact databases also for these reversion mutations. So these are for breast, ovarian, pancreatic, and prostate cancer. So because these mutations are commonly found in these these cancers, so these are these mutations. So there are these databases created. So another use of HRD score, which I feel, which is very underutilized. So at times you find, so this is a case of breast cancer, but still, so this is a case where there were three sisters who had breast cancer, and we had a VUS, which clinically you felt all of them are having breast cancer, they are having this VUS, but you cannot classify it as VUS or as a pathogenic thing. So maybe in such a scenario, HRD score could help, because since it's a dysfunctional, it's quite obviously a dysfunctional uh, BRCA mutation. But if you have a HRD score which is high, it can help you there. Then what is the correlation? This is a very common question I am asked, that is there any correlation between HRD score and MSI or tumor mutation burden? Because what we are trying understand is, if there is a HRD score is high, there is genomic instability, and it is quite likely that if there is genomic instability, the tumor mutation burden or the TMB should be high. But does it happen always? So this is a study which is based on some 30 something thousand patients. So this is like, if you just look at this graph, so the blue dots, the dark and the light ones, these blue dark ones are the pole mutated patients, and the light blue ones are the patients who are MSI high. So patients who are MSI high usually have a high TMB. Okay. And the patients who are HRD score high are, and who are BRCA positive, you can see these patients are here. So this, on this axis, that is the x-axis, you have HRD, and on the y-axis there is TMB. So clearly patients who are MSI high and who are BRCA may not be always, they will not have a high HRD score. So that doesn't happen. But the patients who are BRCA mutated, some of them can have a tumor mutation burden which is high, but again, it will never be as high as that present in your MSI high or patients, or a pole mutant kind of patients. So that is one thing. And then, is there a correlation between tumor mutation burden and your HRD score? Actually, this kind of correlation has not been very well established. There are some tumors, and ovarian being one of them, usually, not always, can have that kind of correlation. But most of the times, this type of correlation cannot be applied. So then how would the future look like? So I think, I don't know, I have explained or you've become more confused about how good is the HRD score. So probably in future, there will be lot many factors which will be taken into account while deciding a responder to a particular treatment. So not only the HRD score, the functional assays, the immune response, the other genomic factors, so everything, the multi-omics kind of approach is what would be there in future. But till that time, we are just adding one block at a time. So this is what is happening. And with that, thank you. I'll be happy to answer any questions.
Thank you, ma'am. If you can just stop sharing your screen, I'll start
Yeah,
with
yeah,
the
yeah.
questions. Uh, okay. So, one of the attendees has asked, does it mean we should test again every time there is a recurrence in the case? And there are, so what she basically wants to know, he or she wants to know is, in case there is a recurrence, should we test the tissue again and do the HRD score on that tissue? So I think the answer is yes. Dr. Moshmi, please, if you could take this up.
Yes, you should. So look, when are we doing HRD? So most of the times, right now in today's practice, there are very few people who are just going for HRD score as like my mid-read genetics kind of score. So most of the people are using HRD score in a comprehensive genomic profiling, where it is a part of the comprehensive genomic profiling. So there it is used. So, and when do we do comprehensive genomic profiling? It is usually done at the last stage, or yes, of course. And that time, if you can get, you should use the latest issue. But if not available, then the previous tissue is good. Practically, we are not doing a mid-read kind of. I think it's costing some 2.5 lakhs. But yes, ideally, yes, you should every time do it.
Okay. And what are we using at our center and how much does it cost if, if we want to know about in the Indian setting, because we know when we send a
Fisher.
patient to
So
Mid-Rad or Foundation One, the cost comes to 2.5 lakhs. So what is available with us and, how much does it averagely cost to the patient? Dr. Moshmi?
not doing HRD. Can you hear me?
Yeah, your
Yeah.
voice was breaking up. Yeah, please go ahead.
So
Madam, I think there is some internet issue.
HRD separately, as I already mentioned. I think there is. So can you hear me?
Yeah, yeah, we can hear you. There
Can you
was a
hear me now?
voice. Yes, we can hear you.
Okay, so the thing is that we are not using HRD separately. There was a time when HRD was offered as some by some company, AstraZeneca, as a compassionate use. Then people were getting it free. Since that thing has stopped, most of the people, if they are using it, they are using it as a part of comprehensive genomic profiling. In our center, this is what we are doing. So we have genomic metrics. So that is only validated against these mid-read genetics for ovarian cancer, and also LOH score, which is validated against the foundation. And we have different cutoff values for that. So that's what we are using. I showed you there are many tests, MOIDX and Illumina 500. So that is also using, and Kaizen. So many of them are there.
Okay, I wanted to know about that was a very interesting case you showed, and PARP resistance is coming in a big way, and you're absolutely right. The BRCA reverse mutations are a big part of it. So, you picked up something on liquid biopsy, which was not present initially. So, I wanted to, the turn the question a bit and just ask you a little about what is the role of liquid biopsy in ovarian cancer, say. So, is this thing coming up, and how does it help?
So liquid biopsy is there and is going to be big. It is getting bigger and bigger.
Yes.
So not only this is one thing, reversion mutation, because liquid biopsy heterogeneous. When you
I
are
think
taking
there
a
is a net
tumor
issue. There is a net
biopsy
issue.
or something, or part of the tumor for testing. Okay. So can you hear me?
Yeah, we can hear you intermittently. Actually, I think the net goes off at your end and then, your voice starts breaking up, but we can hear you now. Please go ahead.
Yeah. Okay. So what I'm saying is that liquid biopsy is there and it's going in a big way. So this it takes care of the heterogeneity. So when you take a tissue and you just send it for sequencing, only a part of it is sent for sequencing. But when you do liquid biopsy, the fragments or the mutations are coming from all the metastatic sites. So that is the beauty of liquid biopsy. And not only that, your MRD, minimal residual disease monitoring. So that can be done by liquid biopsy. And I think there is a lot of work which is done on screening. So liquid biopsy is likely to come for screening, where you will be able to pick up tumors in organs much before they are actually is coming in. But right now, for ovarian cancer, I think this may be just one of this is usually ovarian cancer, it is not done. But yes, for MRD monitoring, it can be done. In fact, CTCs, there is a lot of role of CTCs which is coming. For
Okay.
minimal residual disease, you can use that.
Okay, there is another question. At present, PARP indication does not require HRD if you are considering rucaparib or niraparib, or else can we just advise in a staged manner? First, do the tumor BRCA1 and 2 mutation. If positive, no need to go for HRD. If negative, to go for HRD. Dr. Moshmi.
Yeah,
It's,
I think
yeah,
that
yeah.
is sensible. You can go
Yes.
in stage
So I
manner.
think, yeah, I would agree too, especially in a resource constrained conditions like ours. That's the way to go forward. And also to consider, yeah, whether the patient can actually afford those PARP inhibitors if they are not available on a compassionate ground. Yes, that is right. So any other question? Please, if you can put it on the chat box or the Q&A. Meanwhile, I'll just share the ESMO guidelines. These are the guidelines which are present in which were shared by ESMO in 2020. Sorry. Can you see my screen, ma'am?
Yes, yes.
Yes, so these
Visible.
are the ESMO recommendations 2020 on the biomarker testing. And they said that, like ma'am rightly said, BRCA mutation test, tumor and somatic, they exhibit good clinical validity by consistently identifying the subgroup of patients who will benefit from PARP inhibitors. However, there is an insufficient quantity of evidence to determine the clinical validity of individual or panels of non-BRCA HRR genes for predicting a PARP response. And this is something Madam actually explained very well that, right now, none of the panels are able to actually accurately determine whether this patient will or will not respond to PARP inhibitors. And, the negative predictive value has to be high. And as of now, although the functional assays, ma'am rightly said that, this is coming up in a big way and should come up and would probably be cheaper than the HRD score. Right now, according to 2020 guidelines, of course, these guidelines would gradually change. There was insufficient evidence to determine the clinical validity of BRCA1 or RAD51 promoter methylation to predict PARP inhibit, partly due to concerns regarding the analytic validity of previous studies. However, these are 2020 guidelines, and I'm sure with now other trials coming up, gradually things will be validated. And like you rightly said, RAD51 is something which we can look at, especially in a research setting in a clinical trial, especially in Indian context.
Yeah, and it has very good sensitivity. In fact, it might even just replace HRD.
Right. Okay, Dr. Ranu Patni has asked, should we do HRD on endometrial tissue?
So what was there was initially in this was there in the mid-read genetics this thing. So, but what I feel is how you should use HRDs in a comprehensive genomic profiling. What happens is, if you have, I told you there are two alleles. Most of your HRR genes are tumor suppressor genes. They will only become dysfunctional if both the alleles are knocked off. So
Right.
if you have a germline BRCA1 and or you do a so you get a somatic BRCA1 mutation, you don't know the status of the other allele. So
Correct.
what your HRD score tells you is it's give you an idea that okay, that whole function is knocked off. So probably it is the other allele which is lost or whatever. So I feel clinically you should use it like that. So since there are no guidelines for that till now, and these are very evolving fields. So if you want to use it, and that also if you are caught in the last stage and there are nothing left and you want to take a decision, so you can use it in that scenario.
Correct. Right. And so I think, would you say HRD would be something if, if you're dealing with, say, type 2 cancers like high-grade serous or papillary cancers, would HRD score help there? Because now there are studies on the role of PARP inhibitors, especially in advanced type 2 serous papillary cancers.
Look, I told you, na, guideline wise, it's only ovarian cancer,
Right, right.
but the same thing can be applied to breast cancer also.
Yeah,
So, but this is off the cuff. If you have to decide on something, okay, you're not left with anything, and you need to decide your BRCA1 is negative, somatic and germline is negative, and you don't have anything left, then maybe you, if you have a HRD score, you can think of.
right.
And obviously, you need to talk to your patients if you're deciding on that.
Absolutely. I
But it
agree.
is not an indication.
Okay. So, uh, excellent presentation, ma'am. So I think one of the attendees has asked if we can have a lecture on liquid biopsy next time. Yeah, I think so too, because this is an upcoming topic and we would love to know what is
Yes.
the current role of liquid biopsy because it's coming in a big way. And we should definitely know what are the upcoming roles of liquid biopsy in terms of gynecological cancers. Yes, we'll take that up. Thank you very much for that topic. Yeah. Anything else? If anyone has any other questions, uh, we are nearing the end of the time, but we are happy to take any questions. I think that's it. Yeah. Okay, so thank you very much, Dr. Moshmi, and thank you for all the attendees for attending this. This was a great eye opener, and I hope, now we are a little clearer on, when we see these reports, what it actually means, what the scores mean, and, how it has to be correlated in the clinical scenario, and how in spite of, having PARP inhibitors, we are now coming up with cases of PARP resistance. And, if we have this, what all can we do? So, Dr. Suryakanta has asked some clarification on telomeric allele imbalance and LST. Madam, if you could elaborate on that.
Yeah, I'll have to show you my
Yeah,
present.
yeah, please go ahead, share your screen.
Yeah, because these are
I
actually
think that's a
bio.
good question. I think we were reading about this and yeah, we can actually discuss in some detail. We have time.
Yeah, because these are bioinformatic things, and it's difficult for a normal person to understand. Okay,
Yeah.
so HRD score is basically sum of these three things. So first is loss of heterozygosity. So I had explained what does loss of heterozygosity mean. So there is a definition. This loss has to be more than 15 MB but shorter than a whole chromosome to count it as one loss. Okay. So and the loss of heterozygosity can be a loss of one allele or it can be copy neutral loss. So by copy neutral loss, as I explained earlier, it is the one allele is lost, but the other is amplified. So apparently it appears as a the normal, there is no LOH, but it is a copy neutral loss. Okay. There are two alleles, but they are from the same parent or the same allele is amplified. So that is copy neutral loss. And then coming to what is telomeric allelic imbalance. So this can be either a gain where you add or a loss of heterozygosity, which extends to one of the subtelomeres but does not cross like the centromere. It is lesser than half of the arm. It is one of the arm, but it does not cross over to the centromere. And the size has to be more than 10 MB. So that's a definition by definition. And the third thing is large scale state transition. So these are large areas more than 10 MB and which are less than whole chromosomes which are lost. So I think I have a diagram here also. This is a HRD LOH with two chromosome breaks. So here you can see there is a, if there is no break or there are two alleles, so what we usually see is a straight line. So if you come to my lab, I can show you how we look at these. So what we usually see is a straight line, but if you can see there is a loss, like it is falling below. This is what loss appears to it. So there are, this is the LOH, this is the break, and the length has to be more than 10 MB. So we will measure. So here, if you can, I don't think you can see, it's written something MB, and there is also something MB. So you subtract, it has to be more than 10 MB, then only it is counted as a loss. So when you add these numbers, So it has to be more than 42 to call it a HRD score high. Anyways, as clinicians, you don't need to get into all this. Only
Yeah,
thing is, you just need to know that this is a statistical thing which has been done and how they came to it. They tried doing it separately, and then ultimately they found that a combined thing was what worked best. So
right.
if we combined all of them and they had a score, so that is what worked best, and that's how they devised this cutoff of 42.
Correct. So, like ma'am rightly said, it's basically a sum of three tests: loss of heterozygosity, telomeric allelic imbalance, and large-scale transitions. And when we add them up, as you can see on this graph, if the cutoff was 42, any patient who had a total HRD score of more than 42 was more likely to be BRCA deficient and hence respond more to PARP inhibitors. So that is absolutely right.
Even the patients who were BRCA intact, like not deficient, they responded clinically. So how this came up, this was based on the clinical findings. They responded. It was
Right.
not only statistical compared with the
Combined with
clinical findings.
right.
So that's
Right.
how it.
Yes. Okay. Yeah, I think yeah, these are all the questions. So thank you very much, Dr. Moshmi. Thank you for this excellent talk, and I hope this has been an eye opener. And when we see our patients and we are discussing in tumor boards, we also understand, what this means, why a patient has been offered PARP inhibitors, and why, in some circumstances, these PARP inhibitors can also not work, or the patient can become resistant. And so I hope this has been an eye opener, and we will continue this forward. And definitely, madam, we would like to invite you maybe in the future for learning more about the role of liquid biopsy. In the meantime, in case anyone has more suggestions to include some topics in Indigo, you can put it up, or I will just share my email address here, and everyone can just put in their suggestions as to what would they like in the next class. So, and if any other question is there, please kindly put it in the question box so that we can add. I'm just adding my email here. And in case you guys have any other suggestions for the next topics, please, it's drkumarneha@gmail.com. Sorry, it's only Gmail is written. So thank you again. Thank you so much. And thank you everyone for coming on your Friday evenings and spending time with us. I hope this was a good learning session for all of us. And thank you, Dr. Moshmi. It was a great presentation. And I think definitely I and everyone learned a lot, and everyone is complimenting you also on the Q&A. So thank you so much.
Yeah, thank you so much. Thank you. It's been nice. I think I will love to have a lecture on liquid biopsy. It's one of the
Yeah, very
things which is
awesome.
very close to my heart.
Right. Okay,
So
so we will definitely invite you in the future for this. And we would also like to know more about, what is the role of liquid biopsy. Thank you. Thank you again.
thank you, and good night. Yeah.
Good night. Bye, everyone.